Hello everyone, welcome again for our new video for the continuation of the implant positioning. Today we are going to talk about the width, the faciopalatal direction. Last video we have talked about the direction X, which is the mesiodistal direction. Today we are going to talk about the width, the faciopalatal direction. It's mean buccolingual or from anterior to posterior. Let's say buccolingual better or faciopalatal. So when we talk about the faciopalatal direction or the width, we have to talk about two categories. We are going to talk about the faciopalatal position and the faciopalatal direction. If we look at the picture here, picture A, let's say, and B, let's look at the A. The faciopalatal position, which we are going to talk about it first, it's how to point or how to put the direction in the buccolingual or faciopalatal. It's mean it's here, or it will be here, or it will be here, or here, or here. This is the position. Okay, regarding to the faciopalatal direction in picture B, we are going to know where exactly, if we consider this is the buccal here, and this is the lingual. So we are going to talk if we will put it like here, or like here, or like this. So this is the direction. And that's here the direction. And in A, here is the position. So let's get started with the faciopalatal position, which is the number one category. So regarding to the position, let's talk about the position. Actually, doctors and my friends, the implant in the position should be 2 millimeters from the facial or the buccal plate. So we have to keep at least 2 millimeters away from the facial or buccal plate. Yeah, if we consider that it's here, we should keep here 2 millimeters. In comparison to the lingual plate, we have to leave 1 millimeters only at least from the lingual plate. So why? Why the buccal or the facial plate should be 2 millimeters? Okay, the facial, if we leave less than 2 millimeters from the facial, it will lead to bone resorption. Why resorption? Because it's not dense as the lingual plate. So the lingual plate already it's made more dense than the buccal plate, and it's not in the aesthetic area, which make us we can leave at least 20 millimeters. In the other side, the buccal plate, we should keep 2 millimeters, especially in the anterior part or anterior area where aesthetic will be compromised. So in that area we should leave at least 2 millimeters. We have to mention something very important regarding to the early diagnosis of the width of the implant site. Actually, for the beginners or for the people who or for the practitioners that they could not estimate real direction and real position for the implant, we can always go for the CBCT. This is a three-dimensional cone beam, which can identify and locate exactly the position and the direction of the implant by seeing the 3D dimensions of the implant site regarding to the width, to the height, and to the length, the mesiodistal. So let's look now for the direction of the implant site or the direction of the width of the implant site. Okay, we have three options, okay, which is one of them that is the master, which is number 3. Let's select this as number 1, number 2, and number 3. Number one is the similar to the facial direction of the adjacent teeth. It means that you put here in the picture number one now, we put the implant and look to the facial profile or facial final prosthesis will look like the adjacent teeth. Where is the direction of the adjacent teeth? We can put the implant and estimate that direction of the crown will be like the adjacent teeth. Regarding to number two, within the cingulum of the position of the implant. If we look at the picture number two, you see the implant direction. It will be the implant and the abutment and the hole for the screw in the same direction. So it means it's a screw retained. Screw retained. We fix that by screw. There is a cement retained and screw retained. And number three, under the incisal edge of the final restoration. It is the master, or we can go, it's the ideal. Okay, let's be scientific more. It's the ideal position. It means in number three that the implant and the abutment are under the incisal edge of the final restoration of the implant. So we, after the final restoration or the crown of the implant, the incisal edge will be in the same direction of the implant. So in this type, we have to make it little bit lingually. So we can fix it lingually, or it's slightly lingually, it will be better. Okay, let's take everyone and take a brief conversation about it. So if we look at type 1, which is the similar to the facial direction of the adjacent natural teeth. So let's look here first of all at the comparison between the natural crown and the implant abutment crown. The implant abutment crown. If you remember on the crown and the bridge, when we do a preparation for the crown, in the centrals, we do it in two planes. Why? Because it mimics the incisal edge or the incisal facial crown. It comes in two planes. That's why when we do preparation, do it in incisal planes. So you can notice that the incisal edge is little bit lingual in direction. Okay, so in comparison, if we go to the abutment of the implant the implant abutment already small in diameter and in size, so it make us difficult to make it in two planes. That's why logically, to have the incisal edge the same, you have to shift the implant little bit lingually or palatally, so you will have the same incisal edge of the natural crown. Okay, what if we put the implant too much facially, or we put it shallow? We did not put it too much down inside the bone. We will have here a problem that the crown and a part of the implant will be aesthetic, not good, and obvious and clear. It's like a black line or a triangle coming out from the gingiva. So you have to take care always to put the incisal for the incisor, the implant for the incisor, little bit lingually, not too much lingually, little bit lingually, and deep 2 millimeters under the crystal of the bone. Okay, my friends, what if someone put the implant too much lingually positioned in direction, in faciopalatal direction? What we put it too much palatal or lingual? What is there a solution there? Yes, there is a solution. Let's go to type 2 now in relation to the cingulum or to cingulum position of the implant. Okay, in this position, we put the implant and the abutment within the screw. It will be within the cingulum, so it's a screw retained. Let's say it's a screw retained implant. There is a cement retained and there is a screw retained. So in this type, we make the crown too much, little bit extend from 2 to 4 millimeters facially. So this, if you remember in the crown and the bridge on the prosthesis and the fixed prosthodontics, we called it a ridge lap. That to extend the crown facially more. So it's logic to be in the cingulum, so the crown will be top. Okay, when we can use this, we have indications. Let's see the indications. It will be in low width if we don't have enough space width. I mean anterior posteriorly we don't have width too much, so we can put this technique. And also there is another thing, we can use it if we put it too much lingually, the implant. Okay, in these two cases we can put the implant in the decrease of the width and in too much lingually positioned implant. So but there is a risk in this type, that if you see here at the black triangle that I draw here now, underneath the crown there will be like a sulcus, will be like a groove inside, which will be decrease the health or the gingival health or gingival. It will compromise the gingiva because the food impacted here too much, and it will be very difficult in cleaning. Even if you make the ridge lap subgingivally, it also will be very difficult. Some authors say that if you make the ridge lap, this area here, if you make it subgingivally as you can, it will decrease the food or the cleaning inside. Yes, but it will be very difficult for cleaning, so it will compromise the periodontal health and the gingival health of the site. I want to talk about something related to the both previous types. In this cingulum, okay, this is in the cingulum part, we have to increase the inter-arch clearance or the inter-arch space between the upper and lower, because when we put the permucosal post or the gingival former, it will be no place if you put it too much lingually, because we use it in the lingual position too much, so it will hit on the upper, that's why, or in the lower. So we have to increase the inter-arch clearance. Okay, also we can use the screw retained prosthesis for the anterior implants. But one of the most problems that in the screw retained is the loose of the articulation, all about the screws or the abutment screws, or even make a rocking inside the anterior teeth, which will lead to bone loss. As you know, the anterior or the buccal or the labial bone is sensitive, so bone resorption will be directly. Okay. The other point, if we applied an angle abutments, the angle abutments actually it's higher. The forces applied on the angled abutments is higher than the straight abutments, maybe 26% more higher than the straight abutments. Also, if we lose the 2 millimeters buccally, so what should we do? In this case, we have to go direct to the bone grafting and use also barrier membrane, guided bone regeneration technique. Guided bone regeneration and guided tissue regeneration. We are going to make another video for this both topics. Is very interested. Okay, finally, the type 3. Type 3, which is the ideal position, okay? This ideal position, it's mean that the abutment and the implant is directed exactly when you do the dental implantology. You estimate that the final crown will be under the incisal edge. So the incisal edge, the abutment, and the implant will be in the same direction, which will be the ideal. This will request from you to be little bit lingually, as we said. Okay, we will be little bit lingually on the side and make 2 millimeters here. And as we said, little bit lingually, as you can also adjust If it's lingually, you can adjust, or any mistake, you can use the angled abutments, or you can modify and readjust it in the at the prosthetic part more than if you go anteriorly. You go also down 2 millimeters under the crest, or 3 millimeters under the free gingival val margin. So that's all about the width of the faciopalatal, the width or the faciopalatal position and direction of the implant. Dr. Shadi was with you, and I am very happy to talk to you, and I hope that it will be really clear for all. In the next video, inshallah, we are going to talk about the depth or the height of the implant coronoapically, and please do not forget to put like and subscribe so you can see any update, and have a nice day.